Well, I'm Dr. Jim Del Rosso, the editor-in-chief of Clinical Dermatology of the Journal of Clinical and Aesthetic Dermatology. And here I am bringing you some top three takeaways recently that I think are important to discuss. The first takeaway has to do with photoprotection formulations, and we've had some for quite a while with many of the companies that make great photoprotection products that we have available over the counter, bringing us not only sunscreens or sunblocks to give us protection from burning from ultraviolet light, but also additives such as antioxidants and others that reduce the changes that are associated with visible light and pollutants in the environment that come from reactive oxygen species. Take it one step further. We're now able to prevent with the sunscreen and sunblocks that we typically have had for a long time and have even improved in formulations, and also correct damage that has already been done. And an example is with the addition of what are called photolyases, which humans don't have, but plants and some animals and plankton have within their structures to prevent from damage because they're out there getting exposed to light all the time. And what happens in humans have innate systems to counteract some of the damage that happens genetically within the skin that leads to photo damage that can contribute to photo aging, but also development of actinic keratosis and skin cancers. So that's another important aspect of it. So when there is exposure to ultraviolet light, there are damages that occur genetically, what are called cyclo butane pyrimidine dimers. And these are dimerization of this of the double strands now of DNA that actually interfere with normal genetic activities within the skin and promote skin cancer development. So photolyases, for example, in the formulations, once those are already formed, that damage has already gotten into motion, can reverse those by taking out those dimers and getting the skin to go back to normal in its normal genetic structure. So this is very important because it both corrects and prevents. So you have those two different components to photo protection, and you add in things like peptides that can reduce fine lines and wrinkling. You add in antioxidants that reduce the damage of reactive oxygen species and visible light. You're getting really a triple activity against photo damage and photo aging. So those are very important. And there's a few different companies that have products on the market that are routinely available to do that. Second is a very important recent approval. We now have with topical roflumilast that we have both the foam and the cream that now has four FDA approved indications. Once more than Patrick Mahomes has Super Bowl rings, is the way I like to put it in context. And so the approval of roflumilast 0.3% foam had previously been only for seborrheic dermatitis. And if you prescribed it, third-party carriers would demand that that prescription be linked with a seborrheic dermatitis um, diagnosis. Now, with the approval of the roflumilast 0.3% foam applied once a day for scalp and body psoriasis, it expands the use of this particular product, the Zoryve foam. We're all available of the different Zoryve products and the other indications now being FDA approved once a day for adults and pediatric patients with psoriasis on the scalp and body, plaque psoriasis on the body, as long as they're 12 years of age and older. The efficacy and safety are well established and are out there for your review. The third is interesting because we've had tetracycline agents that have been very effective for acne and for rosacea. For rosacea, specifically reducing the inflammatory lesions, the papules and pustules that we see in many patients that have rosacea, and the erythema that surrounds those papules and pustules. We've had tetracycline, doxycycline, minocycline, and even sarecycline more recently has some data. It would be off label for rosacea, but has some data where it is effective in reducing papules and pustules of rosacea. So the tetracycline agents do that. Interestingly, we've known that minocycline can do this, but its use has been focused primarily on acne, even with the FDA approved formulation, the extended release formulation that is weight-based dosed for inflammatory lesions of acne. Now, minocycline has finally gained FDA approval for papulopustular rosacea. And this is in a formulation which is under the brand name of Emrosi, which is a minocycline 40 milligram extended release capsule. So the patient gets the 40 milligrams once a day. It modifies the release to 30 milligrams later. That's a delayed release, but 10 milligrams up front. Very similar to how uh, sub-antibiotic dose doxycycline or Oracea was developed and also FDA approved for papulopustular rosacea, I believe back in 2006. Minocycline has finally arrived. Now, importantly, minocycline has greater lipid solubility than doxycycline and gets very high concentrations in the skin. So we've never really known is if this extended release minocycline or given lower doses of minocycline would be as effective or more effective than doxycycline. In the actual trials that were included in the package insert, we have the data to show that the extended release 40 milligram capsule once a day of minocycline is more effective than the placebo by far in reducing the lesions. And also, we see a definite difference in the erythema around those lesions. We're not talking about the background vascular erythema. We're talking about when papules and pustules go away, the erythema around them is going to go away and dissipate because that erythema is associated with those lesions. But also, what's in the package insert, because it was included in the pivotal trials, was a comparison of the extended release minocycline, 40 milligrams once a day, versus the modified release doxycycline 40 milligrams once a day, the Oracea equivalent. And the minocycline outperformed the doxycycline significantly in terms of the lesion reductions, the papulopustular lesion reductions. So the minocycline was actually proven, and it is on label because it's in the package insert. They included that in the pivotal trials when they developed this minocycline formulation. This data shows that the minocycline is actually superior to the doxycycline, the modified release doses for papulopustular rosacea. So that sums it up. Those are three takeaways that hopefully help you to be up to date on these areas if you're not already. Thank you very much, and I hope you are enjoying the JCAD.